Alright guys, my cat topic is on energy conservation techniques in the elderly, and I found this really interesting article called Resting Energy Expenditure and Carbohydrate Oxidation Are Higher in Elderly Patients with COPD, a case control study. And what the study looked at is they determined that there's plenty of studies out there that have said elderly patients with COPD have higher resting energy expenditure, but none of them looked at the actual proportion of energy expenditure between carbohydrate metabolism and fat metabolism. So that's what they did. So my clinical scenario is you are working in an outpatient setting with an elderly patient who has been diagnosed with COPD, and you are giving him or her energy conservation strategies. And in passing, they ask you, I'm thinking about trying one of these low-carb diets to lose weight. How do you feel about that? And we talked about in class, I think a couple weeks ago, that we can't really we have to kind of be careful about making diet recommendations to elderly, or to any patient really, because that's kind of outside our scope. But I feel like if we have some evidence to support what we're saying, we can make pretty general statements, just giving some general recommendations of what to eat, what's not to eat, what's good to eat for specific patients. And for specific patients with COPD, turns out that they use more carbohydrates than non-COPD patients. So how the study was set up is they took 40 elderly people who are all greater than 60 years old, and they split them in half. So 20 of them had COPD, and they were the investigation group, and then 20 did not have any pulmonary complications, and they were the control group. So what they had them do, they fasted for what was an undisclosed amount of time. It didn't say that in the article, so I found that to be the weakness of the article. I'm wondering if they fasted for all the same amount of time, if they all fasted, how long fasting lasted, if it was effective for whatever you fast when you get blood work done or anything like that. I'd be a little more interested in that. They didn't really go into that. But what they did was measure their BMI and their waist circumference. And they did this kind of as a formality, I think, because other previous studies have done that. For the specific participants they had, that just didn't really matter. They were all pretty much the same BMI and waist circumference. And they had them lie supine, and they remained still for about 5 minutes to relax. They remained silent. And what they did was indirect calorimetry. And indirect calorimetry is studying how your body uses calories in an indirect way. So a direct way would be actually measuring calories you take in, calories you burn. This does it indirectly. And what they did was hook them up to a metallizer. And I googled metallizer, and it's one of those things that you put around your face, measures oxygen, carbon dioxide, things like that. So, and then in the room they had temperature and humidity control. And this calorimetry determined the resting energy expenditure as well as the respiratory quotient. And I will explain that in a second here. And these results they took were analyzed using basic statistical analysis. And in the document, in my CAT document, I have a figure, like a diagram, depicting those results. So resting energy expenditure was determined in kilocalories, and the respiratory quotient, or RQ, is measured in an arbitrary unit because it's simply a ratio. It's the ratio of carbon dioxide eliminated over O2 consumed. So my first question was, how do they determine the difference between fat metabolism and carbohydrate metabolism just by looking at CO2 and O2? And they didn't really explain that in the article, which was another weakness, so I had to do a little digging, and I found out that for the RQ, if in a typical patient, if the ratio is 1:1, so for every 1 unit of CO2 eliminated, they have 1 unit of O2 consumed, that means they are metabolizing purely carbohydrates and no fats. And then if they're metabolizing purely fats and no carbohydrates, then you would typically see a ratio of 0.7. So for every 0.7 units of CO2 eliminated, 1 unit of O2 is consumed. So that's how they determined that. And they used an equation from a study by Gerontology and Hollis. And it didn't really say what the equation was, so that's another weakness of the study. But I went to the referenced article, and there was actually several equations that these investigators used. So I'm not exactly sure which one. I guess we have to assume that it was effective. So anyway, they looked at these numbers, and they compared the control group to the study group, and they found that resting energy expenditure was higher in patients with COPD, which was assumed. Lots of studies have already determined that. And they also determined that the patients with COPD burned more carbohydrates at rest than fats compared to the control group, looking at the RQ. So that means their RQ was closer to 1 than the control group. And so they have 2 theories for why this could be. The first is that a larger proportion of carbohydrates is being used because COPD patients have blocked airway, so they get less oxygen, which means they use a higher percentage of anaerobic respiration than aerobic because they have less oxygen. And when carbohydrates are metabolized without oxygen, they only get 2 ATP per 1 unit of carb burned. Whereas if they're metabolized with oxygen, they get 36 ATP units of carb. You guys probably remember that from physiology. And then fats simply can't be oxidized without oxygen. So COPD patients get less oxygen, so they get less ATP from the carbs, and they can't oxidize fat without oxygen, so it ends up meaning they burn a lot more carbs than a typical patient. The second theory is that elderly people in general lose muscle mass as they get older, and they lose more type 1 fibers than they lose type 2, and type 1 fibers are the ones that do aerobic respiration. Make sure I said that right. Yeah, so less aerobic respiration fibers means they're using proportionately more anaerobic respiration, which means they need to burn more carbs anaerobically. And then it goes back to the reason we just stated. Anaerobically requires more carbs to get the same amount of ATP. So those are the 2 theories why this is. So, clinical bottom line after the study, if your patients with COPD ask you, is it a good idea to go on a low-carb diet because I'm trying to lose weight, you can have evidence here that says low-carb diets are actually not good because you as an elderly person with COPD require more carbohydrates and burn more carbs than the typical elderly patient. So, there you go.